Everybody, and good morning if you're in New Zealand. My name is Mark Jones. I'd like to thank everybody for joining us today. We're going to kick off with this webinar. It's a very special eHealth Space webinar brought to you today by our sponsors, Orion Health. I'm really looking forward to the conversation that we are about to have. As I said, my name is Mark Jones and I'm the founding editor at large for eHealthSpace.org. I'm also a business and healthcare journalist. I've spent a lot of time reporting on many of the issues that we will discuss today, so I'm looking forward very much to this conversation. Of course, I am your host, and so I will be looking after the webinar. I've got the control panel here, and can I encourage you too, as the presentation's going on, we'd really like your questions, and you can see there's a question tab. If you can write your questions as we go along, I'll be taking note of those, and we will have two different points during the presentation today where Dr. Millar can answer the questions. So again, please make sure that you write your questions as we go. I find it's best to do it that way. Just briefly on eHealthSpace.org, we are an independent media site for health professionals and all those who support care delivery. We're passionate about the transformation of healthcare through talented people and the use of technology. And so we've designed these webinars with that in mind. And so I do appreciate you giving us your time today, and it's great to see so many people in the room today for this webinar. Now, I'll introduce our speakers in just a moment. As I said, we do have a few little housekeeping things. I mentioned the control panel on the side here. Now, regardless of whether you're on a VoIP phone or a regular phone line, this chat feature is really what we're going to focus on. And I'd like you to continue to fill those out. And just keep in mind that we won't be actually taking live audio questions. I do want to just focus on that. The other thing to mention to you is that we will be producing a video at the end of this, and you can see that later online on eHealthSpace.org. A quick overview of our agenda today. We will be hearing very shortly from David Hepburn from Orion Health, and he will give a very quick overview of the partnership with Canterbury DHB, and we will also then move into Nigel Millar's presentation. As I said, we're really keen to get your feedback, and so please do keep those questions up. Okay, well, first let me then hand over to David. Thanks very much, David.
Thanks, Mark. Hey, everybody. Thank you very much for joining. I'm going to be very, very short and sweet. But essentially, the journey Orion's been on over the past 20 years has been pretty exciting. And there have been a few key relationships over the past 20 years that have, I think, really transformed and helped us really become the company we are today. And Canterbury District Health Board and our relationship there that's kind of really been probably over 7 or 8 years from our very first agreement, but really in the last 4 years in terms of a partnership agreement has been one of those relationships that I think has driven a lot of tangible value for Canterbury, but also helped Orion really mature as a e-health software company. So it's also been an exciting week for us with our announcement of the South Island PICS, which we won in the past couple of years and are now in a big partnership over the next 10 years with the South Island. I'm sure Nigel will mention that. But without further ado, let me hand over to Nigel. Nigel's the Chief Medical Officer at Canterbury District Health Board. He's a doctor and also a key leader at Canterbury around technology and is responsible for all the technology investments that Canterbury make. So without further ado, Nigel, I'll hand over to you. Thank you.
Thank you very much, David. It's a pleasure to be part of this presentation. I'm presenting to you from New Zealand, where, contrary to what Mark said, our clock is actually ahead of yours, so it's good afternoon from me.
Yes, that was a wonderful faux pas from an Aussie, wasn't it?
Yeah. So look, let me start talking about our transformation in our health system, the way we've managed to achieve some gains in terms of managing demand and producing an integrated health system alongside our partnership with Orion Health, and also our little experience we had with the earthquakes. And let me get to my first slide. What we're talking about here is our journey of transformation. So Canterbury DHB, I hope you can see a slide of New Zealand, the South Island being called the mainland. We cover 500,000 people, an all-risk process where the DHB has all the funding for community healthcare, primary healthcare, owns and runs the hospitals, and also provides the funding for aged care in the community and nursing home and rest home. And we have to plan and fund all these services. We employ about 9,000 people, but there must be about another 9,000 working out there in the health systems that we directly or indirectly fund. Our beginning was a fragmented system. You might be familiar with the picture, hopefully you're seeing now, of a whole set of jigsaw pieces that don't fit, large gaps for patients to fall down, delays in the system, overloads, ED overcrowding, delays in admissions, and all the things that you regularly see in the paper. And they were our friends, the things we learned to live with. But in 2007, we kind of had a feeling enough was enough. We could see when we got the key people in health together, we got about 100 people together from across the health system, the whole health system, not just the hospital, not just primary care, the whole health system. And we saw if we carried on as we were, we need to build another hospital by 2020. And then we saw, actually, if we did that, we'd struggle. We needed 20% more GPs. We'd need 2,000 more aged care beds. And in fact, we had a scarce and aging workforce. So even if we could afford a brand new gleaming hospital and afford to pay the people to work in it, we might not actually have the people. In fact, we probably wouldn't. And it became clear to those key leaders who were present that the current system was unsustainable and it was unethical to proceed with it. We had to think of a new plan. So we had to create a vision that we could understand and use. And this vision that we've borrowed part of from the Redbridge Primary Care Trust in the UK is a concept of putting the patient's home in the middle. You'll notice that the hospital is on the outer edge of the picture, and the patient's home is in the middle, surrounded by those services that need to be close to them. Focus particularly on connecting things. Has to be a connected system, because if we're going to move care around and provide care at the most convenient place, rather than provide care in places as defined by type of care, we need to connect things up. So I'll come back to the idea of connection. We need to build this around people, the people we want to serve, not build it around the health providers or the health professionals. Particularly important, we had to find a common value that would make sense to everyone. So we came to the conclusion that the person whose time was the most expensive and was the most valuable was the patient. And wherever we wasted that, we were causing harm, risk, discomfort, and unnecessary cost. And that turned out to be a brainwave. And I'm absolutely sure that's one of the fundamental parts of what's helped us make a difference. We set 3 strategic goals. People became responsible for more of their own healthcare, so we supported them to provide it. People would stay well in their own homes and communities and be supported to get care close to home. And that would free up the acute hospital sector to respond immediately when either unplanned problems happened, noting that every acute admission hospital is a failure of the health system, another conceptual model, and elective and planned services promptly rather than being delayed. And we really wanted to make a statement, a strong statement, that health was not about hospitals. It was very important for us to step away from that as we owned the hospitals and stop talking, in fact, about the Canterbury District Health Board, which was the funding organisation that owned the hospitals, and start talking about a system. So we talk more commonly now about the Canterbury Health System, which must be resilient. Sorry, I've accidentally gone backwards. So moving on, we set a whole series of things from the very beginning. Going back to 2005, we began with improving the patient journey. A program to be using lean thinking, all the common stuff, but instead of just actually running a lean program involving a whole people, we began to make it systematic. And we learned the value of IT. We learned that if we took the lid off the PACS system, we could track every single X-ray for every single minute or second, every single second, and know exactly who opened it when and how long it was open to be reported, when it was reported, when it was opened and not reported. And that way we learned. We went from a system of up to 3 days to report a complex scan, sometimes scans waiting for 2 or 3 days, large numbers of them, to all scans being reported in the same day, 70% within 1 hour, without any more radiologists. And when we realized that the opportunities around production, we began to make some real gains. Then we moved forwards looking forward from 2006, 2007, we decided to look forward to 2020. We thought then it was a long way ahead, but it doesn't seem so far away now. And then in 2011, we had an earthquake when we had begun to make some changes. And what we learned in the earthquake was that we were resilient. We had a system where people worked together, primary care and hospital were combined and united in their response to an earthquake. And many people will tell the story of how Canterbury improved its health system because of the earthquake, but the answer is we survived the earthquake because of the health system. But I'll pause for some questions now. This is the early part of our transformation. Interested to hear what people want to know about that, whether you have any questions. Happy to answer those as we go along.
So we don't have any written questions yet, but please do if you'd like to just dive in and write some questions for us. And while you're doing that, let me ask you one from going back to the beginning of your presentation there. Nigel, you talked about this moment of epiphany, if you like, where you didn't want to cause harm and you realized you didn't want to waste time. Were there any reports or situations, scenarios that triggered this thinking? What really prompted that awakening?
Well, I suppose it was us thinking of using lean thinking and trying to translate that into a health environment. And we saw that in lean thinking, you want to manage the product to reduce the amount of time where there's no value added and increase the amount of value added proportion. So, for example, but then our clinicians would challenge us and say, look, we're not running a factory, we're not making baked beans, you know. And when we thought about it, we began to realize that the non-value added time construct in lean is waiting time, which for a can of baked beans is neither here nor there. They don't suffer pain and aren't particularly ruined by waiting if they're well canned. So in fact, actually, the value of lean is actually understanding this patient time concept. And it actually has a humanity, a more humanity than in traditional manufacturing. So we realized there was more value in lean for health, and we wanted to express it in a simple phrase, which was that this person's time is the most valuable.
That's great. Now, the questions are coming through. I've got one here from Tim Hines, who asks a great follow-on question. What do you think were the key drivers to convince clinicians to lean thinking? Having that 2-day work or 3-day workshop where we sat aside and we did a number of things. We projected forwards on our current models and began to see the unsustainability. We brought in key industry partners, high-performing industries or organizations outside of health. So we brought in the George Hotel in Christchurch, won many international awards, just to understand about service and efficiency in organization. We brought in Air New Zealand, airline of the year 2 years in a row now. How do you run a flight center? The answer is it's very much like running a hospital, but compared to Air New Zealand, we were total amateurs. And to get people to see there was a world outside of health where things could be done efficiently and effectively. It's great to see more questions coming through. Let me just jump to the next one and we'll try and get through as many as we can. What do you mean by connected and informational or relational? Can you unpack connected, please? And that's from Andrew Knight.
Okay, I'm going to talk more about that as we go through, but and a simple principle, very simple principles, that the ultimate goal is a single health record. Why would you have separate records? So the health record needs to be focused around the person. So it's person-centric and not provider-centric. So it becomes provider-agnostic. That, of course, implies all those connections in terms of wires and systems that join things together. But that's the point we needed to get to. So wherever the patient appeared, the relevant information, the same information was available to the clinicians who are caring for them.
That's great. Clive Gold asks, how did you achieve organizational-wide support for your initiatives? Which is, I guess, related to some of that earlier thinking around lean thinking as well.
Well, I suppose we were consistent. We began small. We began with something we knew we could do, which was around patient flow. And we were pleasantly surprised because, quite often we embark upon fixes for problems when there's a crisis. And my mnemonic is when you only sit down with people when things are difficult, you get difficult people. If you sit down with people when things, feel good, and start talking about opportunities and the idea of projecting forward and seeing we've got to do something, then I think we got to a point where we were able to talk openly about that things had to change. And, change in health is a complex thing. The standard level of change is nothing's changing around here. The next level is maybe everything should change as long as it's not me and everybody else has to change. And then working people up to a model that begin to think, maybe I might change what I do. And finally, when you get to transformation, it's like everybody's saying that anything is up for change. No, there are no icons, there are no specially protected areas. Everything can be discussed. We don't get there every day. We just get there occasionally, but at least we move people up through those levels.
That's very important. Helen Kachator has asked a great question. How are health consumers engaged in the decisions about the transformation?
Okay, we've had a journey with this very early in some of this, very early, quite a number of years ago. We did a project on stroke, and we forgot to include the Stroke Foundation. We got angry phone calls and letters, so we cancelled the project. Waited a month, restarted it, and asked the Stroke Foundation to take a lead and learn from that this is an absolutely critical part. So our standard is we really want to have 2 consumers in every change meeting if we possibly can. We don't achieve that all the time. We want consumers to have reference groups to work with. We want to be engaged with the community, so we set up a consumer council. We did that by inviting to a single large meeting, very large meeting, every single advocacy organization we could think of for patients, every single one. And we sat down for an afternoon and said, well, how do you want to engage with us? And interestingly, a lot of those organizations said, tell us what you want. And we said, we're not telling you, you tell us what you want. When I left for that meeting from the board office, many people thought I would not return alive. But it proved my point that when you sit down with people when things are not difficult, they were great. It was so good that we didn't get to a conclusion the first afternoon. So they all voted to come back for another afternoon. And we eventually came up with a consensus process to nominate and set up a consumer council and make sure that consumer council provides governance over the whole consumer engagement program.
Right. That's a great point. Philippa Van Brown asks, how did you bring radiologists along the journey and to move from a 3-day turnaround and reporting to the same day?
That was a really interesting experience. We had a wonderful clinical director, and the clinical leadership was a really important investment. And I might talk about that later, but we had a wonderful clinical leader. We had great people. But when we did it, we had a production engineering team who went into radiology, found all the data, analyzed it, presented it to the clinicians who said it was wrong, as they always do. And then we went back again with the corrected data because they were right, there was elements were wrong. And then they began to engage because there seemed to be science and data in here. And they began to discuss, and the production engineers were able to give them a science of improvement, which actually eventually made sense to them. When we presented the success to the wider senior doctor body, some senior doctors said, this is cruel, making radiologists work like this, like animals in a cage, just reporting films and flat out. And the radiologists replied very quickly that they preferred this was better. It's a better way to work. They could concentrate on what they were good at. They still had time for their clinical meetings. In fact, they had more time available to take part in clinical meetings. And they went home at the end of the day knowing the job was done. So they preferred it. And obviously there were challenges along the way, but most people were open to discussion as long as they felt it wasn't a clever way to remove resources. It was a way. We didn't take resources out. We simply made things work with the resources we had and then kept on improving so we didn't have to keep adding resources.
Yep. That's great. I'm aware of the time, so why don't we press pause on the question and we'll revisit some of the other great questions that we've got here, because it looks to me like a lot of those will either be answered by the rest of your presentation or we will have a chance to unpack them at the end. Is that okay?
Okay, I'll proceed then. So change leadership we just talked about. Well, we set up a program. We wanted to follow that sort of aphorism that if you can produce a substantial change of thought patterns in the square root of the number of people in your organization, you would change the system. So we set up an immersion leadership course open to all significant leaders from sort of clinical directors, senior doctors, senior nurses, middle to high grade managers from the community, primary care. And we put 12 of them at a time through a course where they are immersed in an understanding change management, understanding lean thinking, understanding good industry processes, going out to visit Air New Zealand in their operations center, designing a project and carrying it out, really a changing thought process. And they come out of that. And one of our senior doctors said to the board a while ago, he was asked about this program. He said, I've never been on that program, but I know when I meet someone who has in the corridor, within 30 seconds, I can tell by what they're saying. So this was a program to help people think differently. We've now put 700 people do it. We've had far too many go through. This has been a key part of making the change, is an immersion change program. Then we had to work out how we were going to agree what we're going to do across the health system. As Muir says, if you go to a health system and you ask how are things done around here for a certain condition, you get more than one answer, it's not a health system. So we set up a process called health pathways that some of you are probably familiar with, and we simply sat GPs and hospital doctors and nurses from both sides in one room and said, what are your problems for a particular subject theme like respiratory, for example. They identified the issues and they began to solve the problems, and the answer was almost always an agreed way of doing things. So now we have a simple way of managing anything from chronic cough to chest pain that's agreed across the health system and available at one click through a simple, very basic website. So, for example, we have a program here for managing heavy or irregular menses, which gets regular and frequent use and has made substantial differences to the time it takes to get people care. Because we could change the care plan. So now most of the care is in primary care. They do the Propel biopsy and the ultrasound, which we authorize if they follow the guidelines. And that means that most women with heavier menses who present with this syndrome can have their treatment started immediately, and about 70% of them have the problem resolved within 28 days in primary care. Of those who reach the gynecologist, most, by far the majority, need surgery, so our gynecologists are freed up to do more interesting and valuable things. We have a parallel website called Health Info, which is the same information presented back for a patient view. So now we can say to patients, this is how we do things around here, this is where you can get information to support your own care. And we simply use a mixture of local information and things we source or link to from outside that we trust. Then we began to work on a process of how do we join things up so we could working together rather than separately. We realized we could not do this by contracting alone. We couldn't do it by incentives, which in my view just create games, or disincentives, which create deception. We wanted something better, so we took the alliancing model that has been developed, particularly in civil engineering projects in Australia. And the principle was that we wanted people to share the responsibilities. So when we came together with a key set of providers to look at an issue, we basically wanted to hide the money, take that out of the discussion and say, how should things be done? And then work out how we came to a decision, which was variable sometimes. Sometimes we had to decide, sometimes the minister might decide. Most of the times we shared decision-making. So, for example, when we wanted to rationalize laboratory services, we got all the key people for laboratory services in the room. We worked out what to do. In the end, we decided we wanted 2 laboratories, one private, one public, and we could rationalize knowing that we had the support of the whole sector before entering commercial process. But most of our work is, what is the right thing to do? How do we get there? Agree it amongst the key providers, and then we work out how to fund it fairly rather than by incentives. This was then partnered by some important things around integration. What we realized in the earthquake was that there were people traveling off around the country who then had no access to their health records. I was a great enthusiast for health records, electronic health records, and I'd been told by my colleagues this was a risky thing because, for example, if there was an earthquake or some disaster, we wouldn't have access to the information. What we learned in the earthquake was that paper records were the problem because all the shelves fell over medical records and you couldn't open the door, it wasn't safe. Several health providers had their records condemned to demolition because the buildings were unsafe, whereas our hospital electronic record system didn't miss a beat. It ran right through. The primary care systems, those which were lost, we tragically lost one whole general practice and the team, but we were able to recreate the record in under 24 hours. However, those records were not accessible around the country because practices had moved, you couldn't find people, and so we had to do something. So we worked out how could we rapidly share information between systems. And this is where we got great support from Orion, who we'd been talking to about partnering but prior to the earthquake, on the basis that we really thought that a close relationship with your key provider around health information systems has to be a good thing. An arm's length vendor didn't seem to cut the mustard for us because it was so core to what we do. And in this context of alliancing, how do we find a partner? So we sat down with Orion Health, and said, how can we solve this problem of sharing information? And we actually had our first meeting 11 days after the earthquake with Orion Health, general practitioners, community pharmacists, community nursing organizations, and the hospital team. And we came up with the concept of simply finding a new space, creating a new space to share information into that could be accessible at every point of care. So it looks like this. So in the middle, we have this thing called Health One, formerly ESCRV. And it's a process of sharing information from the hospital, general practice. So the general practice systems run an hourly update for a summary of their information is uploaded into this space. Nurse Mord is our community nursing organization. In community pharmacy, every time a prescription is dispensed, it automatically uploads. And the hospital system is joined in because it's actually on the same Orion Health platform. This means that when a patient goes to primary care, is seen by a community nurse, or in the community pharmacy, the information is available at the point of care. And of course, in the hospital, if a patient, for example, goes to ED, we can immediately access all the medications that have been dispensed in the community and a summary of the general practice record and so on. Prior to this, when a patient turned up in the emergency department or the after-hours general practice, their medical record was commonly what was in their head. Now we have something more tangible to make a difference, and there are many stories of what a difference it made when people saw things they didn't suspect in that record. It's simply using the Orion Clinical Desktop to share the information across the system. It's an opt-off system, meaning that all the patients are automatically enrolled unless they choose not to. We had to find some way of managing privacy. There are a number of levels to this. I won't go into all the details, but the GP can prevent information being uploaded at the patient's request or their initiation. And then we have this idea of a matrix, which is down the rows are all the types of information, the columns are all the professions, the red box is where there's no access, and the green was where there is access. We put this on the screen in a joint large meeting, and interestingly, I put it up with largely green with some red. And then during the course of the conversation, it went red about who couldn't access information. And then suddenly, in the last 10 minutes, large portions went back green again. A very interesting discussion, lots of interesting dynamics around who did what, and a realization of the value of community pharmacists, which has been turned into an increased mana and an increased role for them. But this gave us a point of discussion, the ability to talk openly about privacy, which was the concern people presented to the table. But of course, the concern they really had were things about what would this mean for the patients, what would it mean to my model of care, what would it mean for my business, and so on. So we now have 480,000 Cantabrians enrolled in this system. We simply appear in the press as often as possible, local radio, articles initiated by the DHB to say how to opt off, and so far, the last count, 300 people have opted off, and we've had a handful of complaints which have been largely resolved without problems. Parallel to that, we had to have some way to collaborate across the South Island. And again, working with Orion, we've come to the concept of the patient information care system, which you might look at first and see as a hospital patient administration system, but it's much wider than that. The idea is to have the same system across all the major hospitals in South Island. So when a patient moves between hospitals, it's the same as moving between wards. And to build that in such a way so it's expandable into community and primary services when and if they wish to take it up. And that's been really exciting developing that, and we expect to have it implemented in the latter part of this year. We had several key programs to make things happen. We had an acute demand management system, which was to allow GPs to provide enhanced services to their patients. The GP simply has to say, I think this person might go to hospital without this service, and we'll support it and fund it, which might be intravenous medications, it might be treatment for a DVT, it might be investigations, it might be just plain community support and nursing over a weekend. And that makes a huge difference, as I'll come back to. We have the CREST program, which is simply an enhanced rehabilitation hospital at home program. And we have a medication management service. These sorts of things you've all seen before. They're the sort of standards that people often work to. But from our perspective, because we had a joined up, connected health information infrastructure, these things became real and really easy compared to before. The CREST program started after the earthquake, about 3 or 4 months afterwards, and from conception to beginning took 3 weeks. And we have a very significant falls prevention program in the community, again, using the same information. And you might see that little graph there talks about the number of old people coming to emergency department with falls, which is, funnily enough, gone very flat and appears quite aberrant. So what does this really mean? What is really happening? Well, the first thing, this is our occupied acute beds, and a very strange thing's happened in Canterbury. This runs from 2012 to this quite recently. It's flat. I don't suppose I need to say any more than that, really. We're particularly focused on older people, how they're going to remain at home. So this is ED attendances, and the break point is just around 2011, initiated by the earthquake, but we've never picked up back to where we were, and it's largely flat. Very strange. It's not because all the old people left town after the earthquake, because in fact we've got more old people than we had. Something has happened in the system where we can provide alternative methods of care or even avoid the illness in the first place. If we look at the proportion of people going to ED, you can see that's falling steadily, now down to 23% in a year, and we expect that to keep falling further. We really want people to be in their own homes, and in fact, if I ask my patients, I'm a geriatrician, what they want to do, the answer is almost always to go home. And when I meet them in rest homes, I say the same. So the proportion of people 65 and older in residential care, which in New Zealand includes hospital and rest home, funded by us, you can see is steadily falling. So what that means for us is we now have 400 less old people in residential care than we had in 2006, 2007, despite a large growth in the population. These things give us headroom, the ability to do other things with the resources that will be committed to these programs. Now, some principles that we're working towards. We haven't achieved these, but we need to have vision. So the vision forwards is some very simple statements that we stick to and we challenge people with. From our perspective, the health record belongs to the patient. It should be focused on them. They should be able to read it, to annotate it, to add, to make a comment. I disagree with that. That's rubbish. Or in fact to say, excuse me, doctor, be careful, that's my right leg, not my left leg, which would greatly improve quality. They should be able to contribute to the record, to add to it, whether it's their Fitbit mobility, their blood pressure, or perhaps textual information about their symptoms. That's important. And finally, to have some control over it, to see everyone that's accessed it, and to be able to decide who can access it and who can't in a managed way, would mean we'd have much less of a concern or worry about privacy from ourselves and the patient themselves. The next thing we're partnering with Orion on is how do we make the record focused on the person, person-centric, agnostic to the provider. So our shared system is shared and governed by the health system as a whole, including the consumers, not by the provider. Similarly, for our hospital patient administration system, it's shared across the whole South Island. It should also be device agnostic. So in other words, it comes up on the device that's relevant to the context you're in, and be agnostic to the location of the patient or the person providing the care. And finally, how are we going to measure all this? What are the things that are important about implementing health IT systems for the future to join up healthcare? They must meet these four characteristics. They must make it safer. They must make it more effective. And when I mean effective, I mean healthcare outcomes. Make it more efficient, and that's more efficient in patient flow, not just in using electricity or numbers of servers or something like that. It's actually efficiency in terms of patient flow, which is the ultimate efficiency from our perspective. And finally, it must make it a better experience for the patient, but also the staff member. I don't want to lose our staff's time, updating information or trying to find things in impenetrable screens. So that's a summary of what I have to say. I'm very happy to answer questions that I think Mark is going to manage. Thank you.
Absolutely. And thank you very much, Nigel. It's a fantastic review of what you've done. And there are quite a few more questions, which is fantastic. We didn't get to this one before, and you've partially answered the question, what are the metrics that let you know you've made a difference? And I liked your comment that particularly I think it was the beds chart spoke for itself. Have you had any other feedback from other stakeholders which have helped, if you like, give you both quantitative and qualitative feedback on knowing what an impact you're making on communities?
Well, the qualitative part is, for example, older people, we get regular feedback, those engaged in the CREST program. getting back to my own home was so important to me. This is what matters to me. And then we get feedback from those providing acute care out in the community where previously they felt isolated, unconnected, where they can easily access the right care, they can access the means of care through health pathways, they can access the patient's information. From our perspective, that's really important. And trying to focus on the idea that acute admission to the hospital is a failure of the system, how can we get there earlier? We set a task to give us examples of people being saved by the systems. The answer was that the saves were so far upstream you couldn't really find them as clearly as we expected to. So we felt confident we were making a difference.
Fantastic. Does every patient have a unique identifier for the whole system? That's a question from Chelsea mentioned.
Oh, right. Well, presumably Chelsea must be from Australia. We're in New Zealand where everyone's numbered in case they get lost. And then they have the National Health Index number, which is unique to the patient. The duplicate levels, for example, one patient have two numbers, are now getting vanishingly small, a matter of 1 or 2%. So everyone does have a number. So that's our key identifier when information gets shared across systems. Technically, we generally put another identifier through just to make sure there hasn't been an accident in the process. So we put through name and date of birth when we're sharing information and packages. But from our perspective, we would be struggling without that. And I feel sad and upset about countries or domains where such things are legislated against, because if I was a patient, I would be most distressed to see that I'm harmed or get worse healthcare because of some ideal legislation.
Got it. What percentage of improvements to date would not have been achieved if you were not a fund holder across care settings and providers? And that's a question from Tim Smith.
The answer is who knows. All I'd say is we did quite a lot of work like this that set some of the framework a number of years ago before we had the funder arrangement. And we found it relatively easy to have the same discussions. You just have to take more time to get people to realize that the funding isn't the issue. It's the way you provide care. And in the end, if there's funding, there's money. It might come from several streams, but if the care providers can agree and align themselves and become partners and not be scrapping for the money, but be competing to provide the best quality care, you can do these things.
Great. Now, another question going back to stakeholders. How did you overcome the different cultures existing in the salaried hospital system and the private GPs and bring them together with common purpose? A question from Chris Pickett.
Yeah, that's been an interesting journey in Canterbury, and I think it was recognising that everyone's an equal player in the process and making sure that the people where you see cultural differences end up in the same room, because the cultural alignment of doctors is much greater than the cultural alignment of their payment systems. But you have to give it time. And when we sat GPs and hospital doctors down together, the hospital doctors kept complaining, you're sending the wrong people to hospital, and the GPs said, well, you do different things with every time with no idea who to send. And the hospital doctor says, do we? And then you get to a moment where you have a discussion, you realize we have the same shared problem and we can solve it.
I might try and group a couple of questions together here. There's some more around the stakeholders. Cecile Egman, excuse the pronunciation, says, thanks for the inspiring presentation. Can you tell us how private specialists fit into this model and have they been included in the consultation process?
So we have a range of specialists in Canterbury. Our private sector is probably not as big as Australia. Most of the private specialists have a role in the public sector, not all. So we have some engagement, not a direct engagement with the private surgical specialists who don't work in the system at the beginning, but now we do. We're, for example, with the Health One program, that bubble of shared information has become so important. The private hospitals, the private surgical hospitals have written to us and some of the private specialists and said it is now unsafe for us not to have access. So we would say to them, that's great, you would like access to the shared information. It's not ours to give or take away, it belongs to the patient, so we should work with you, but what will you give us, the system? And the answer has been universally, we'll give you any information you think you need to make it improved. So it has been since it produces an engagement relationship where it becomes attractive to be part of it.
Anthony Sara asks about the changing culture of the specialist hospital staff and how has that changed?
Well, I suppose it is around leadership, and David Mates, our chief executive, who's a wonderful, inspiring chief executive, said to me, as we were traveling to some post-earthquake meeting, and we'd been amazed by the ability of people to respond to the earthquake. He said to me, "We've got great people, Nigel." And I said, "Well, yeah, we do actually, but we employ 8,000 people, so we must have great people. Just so happens we've found them." And it's been a process of focusing on leadership development, using that Accelerate program as a launching platform, and helping the people who wanted to learn more and to take more leadership, and seeing the leadership transform from being senior doctors who were in it because no one else would do it, and they're feeling their role was to represent the doctors, to now to a point where people in it because they want to do it, because they want to make it a better health system. You don't do that overnight. You can't, start today and have it all fixed by next year. You've got to work through this process to get people to see there's a bigger system than just their care they're involved in providing themselves.
Mm. Now, Tim Hines asks a great related question, which is, how important is it that clinical leaders drive ICT-connected care? Often in my jurisdiction, IT are the sponsors and it doesn't seem to work.
Well, the answer is you probably don't want the IT projects. You want clinical projects that are using IT. So that Health One project, we made it very clear, that was a clinical project. We needed the key leaders and some very smart IT people, but in the end, the biggest thing at the beginning, not now, the biggest thing was a socio-political and medical organizational thing to get people committed, and then to get people committed to getting the right solutions, and then technically making sure we could deliver them. And there are very few IT projects in health. Most projects are either clinical or business.
Right. And then I guess on the IT side, point-to-point information sharing is far more acceptable than point-to-share. How do you increase value to providers to enter into this space? What are the minimum engagement terms of a range of providers, etc.?
I can give you a mathematical equation. We all want to do point-to-point makes logical sense. So if you have two providers, you've got one connection to negotiate. If you've got three providers, you've got three connections. You've got four, you've actually got six connections. You can see something happening here for the mathematically minded. The number of connections you need is n squared minus n all divided by 2. So in other words, it approximates to n squared. So if you've got 200 providers, someone can work out their head what approximately 200 squared is. And you can see that's a model you could do. The lawyers would love it, but I don't think it would actually deliver for the patients. If you go to a shared space model, which is a quick fix to get going, once you get past the size, it works. The number of connections you need is simply the number of providers, and it becomes a very different matter to make it work.
Absolutely. There are more questions flowing in, which is great. And I think given the number of questions we have left, we will go up until the hour, if that's okay with everybody, and that's all right with you. Nigel, the question is, given the consumer is central to the system and digitation was a core focus, how important was telecommunications and connectivity between the hospitals, and what challenges did you encounter and overcome? A question from Craig Johnson.
I suppose we were fortunate. Firstly, we had the partnership with Orion that helped us get through the technical issues about joining systems. That system technical, sharing information between how you format information, how we have an engine to share. We use the Rhapsody engine to share information between systems so it's streamed in the right direction. We were very lucky with the connectivity. We're not lucky with its infrastructure provided in New Zealand. We have a secure health network, which any registered health professional can access with some accreditation arrangements. It's quite straightforward. They only need to use one of 4 ISPs, which are available in almost all parts of New Zealand. And if they're using one of those ISPs and they have accreditation, they can get a secure health network connection, and it's all on from there, really.
Yeah, absolutely. Now, let's go to another one. Are you doing any any analytics on the data to improve outcomes, efficiencies, or general health of the population?
Well, of course, what you can see behind this is a big data opportunity. As we develop our information, our data set is growing exponentially. So we are actually making sure we bring data together into a shared space, into a warehouse at the present time. Although we probably like something more flexible in a warehouse, we'd like to be like Twitter and do something a bit more innovative. But we've got a large amount of data, and we are using that data. Some of that information you see is presented using a mixture of Tableau, and we work with a group called Signals from Noise in the UK to make sure we can represent the whole patient journey, not just bits of it. So that's been a really important part, and that we now have a kind of dashboard model where clinicians, say the orthopedic surgical group, can explore their information and understand what happens to their fractured neck of femur patients from the moment they hit the ambulance to the when they leave rehabilitation.
Yeah, there's a lot going on there. There's another question here about. Let me have a look here. There's a lot happening. Do GPs and other primary care providers access the hospital-based systems to view results or for online bookings to clinics, etc.? And that is a question we have here from Paul Hussain.
Okay, so currently the main use of the system is to access the hospital record. So all our laboratory results in Canterbury, wherever the samples are taken, go into one shared repository, which is available through the Health One network. So they can see results wherever they've been done. Immediately they're available. So you could have a blood test in the hospital, the GP could see it later that afternoon in the clinic, or vice versa. And similarly, all the correspondence from the hospital, all the referrals coming into the hospital are all in that system, along with rich information about operation notes. There are appointment details available, though at the present time we don't have functionality around booking appointments, but that's our expected program with the PICS program around, are working with us around how we make it possible to book appointments easily and simply from right across the South Island.
I think a related question is from Anil Kamath, says, could you talk about the collaborative process between public system and private primary health system, i.e. drivers aligning goals and agreements to participate?
It's been a really interesting experience. You would think that why would GPs take on more work, more complex work, managing their patients with pneumonia, with a curve 1 or 2, they can manage them in the community, managing their people with deep venous thrombosis, and some now with pulmonary. Why would they do that? Why would they want to be involved in that? And the answer is a lot of what GPs do is kind of discretionary. So they've managed to reshift their program in order to do this work. And when I speak to GPs, I say, what do you get out of this? In fact, that's what the King's Fund people said to us when they came to review us. They said, what do GPs get out of this? And the answer is, it's what they're trained to do. It is interesting. It is exciting. It is actually real sort of hands-on healthcare, knowing they can do things that previously they would have thought risky, because it's authorized by the system. We've agreed this is okay, and they get really good backup if they need help.
I agree. And Clive Gold asks, do you or are you planning on extending the health record to include all data and ologies, home monitoring, etc.?
Yeah, so we have ambitious plans about everything, of course. The key thing for us is we've created the model where we can join data in, and our next target will be to join in information from our aged care assessment program. For example, all aged care assessment is done in a standardized format across the country, so we want to join that in. We're talking to our cardiology team about how we bring in their program for home monitoring of weight into the system. The thought we have behind all this is wherever we see data, we want to preserve it. Don't lock it into an information set. Keep it as data, and we'll work out a way to bring it in the system. We're at the moment working across the South Island to get a unified model for heights, weights, and blood pressures. So yes, we're looking to make sure that the core data is preserved in the system, and then we can create information views.
Maltstein asks, does SNOMED play a major role in the data that you collect and share, or is there another schema that you're using?
Now, at the moment, SNOMED doesn't play a major role. Though it is our target. New Zealand has a license for the health system for SNOMED, and if anyone wants an opportunity, the opportunity, I think, for SNOMED usage is for someone to develop the ultimate SNOMED code lookup tool. And that's what we need, that we can implement in any field and any system that needs a SNOMED code. And then it moves away from being complicated coding to being everyday, and then we can teach it in medical school. So that's the vision, and I've just been discussing that with our National Health IT Board as to how we can find a way to commission the work to make that happen, because absolutely SNOMED is where we need to be going, and that's our commitment in New Zealand.
Okay, great. We have a little bit of time. I'll try and I'm doing my best to sort of pick off all of the questions here, which is great. With having public and private laboratories in the same hospital, how do you determine what tests go where? And considering there would be a crossover of tests and that private labs will only do the work that they make money from, says Mark Bishop.
Okay, so they're not both in the same hospital and the same health system. So actually, the private labs are based out near the airport, convenient for samples from elsewhere in New Zealand, and they run in the community, and the hospital lab runs in the hospital, but also to some degree in the community. The patient can choose. If you give them a laboratory form, they can go anywhere they like. Most of the tests are done through the private system. I mean, most tests are available in the private system. Where not, they can simply subcontract them back to the hospital. And we have a funding model which is more of a capacity model than a fee-for-service model. So in the end, we want to pay a certain amount for laboratory services per annum. And if you're a laboratory, as long as you have a good idea of your demand and if you know your income, life gets so much easier.
Okay, sounds like you've made some great progress there. George Margellis says, did you see any advantages of mobile devices versus desktops as a means of accessing information?
At the moment, we're a bit mobile. We're not fully mobile friendly. At the present time, most of our information sets are PC based. We do have some visibility through mobile devices. One big transformation we made in the hospital system was move to ultra thin client using VMware. That's been a huge success because we've gone from 30 seconds to log in to the system, find your patient, to 7 seconds to click on and find the patient you already had open before. And that now has mobile visibility, although not completed app functionality. It still means that our Orion Health system can become visible to our senior doctors wherever they are through their iPad or similar. And we're working with Orion on a process. They've got a pathway laid out for us during the course of this year to get some of the key elements of information to be mobile.
And you see mobile being key to the strategy going forward?
Yeah, as I said, I think one of the key things is the information needs to be device agnostic. And it depends on the context. You can't have the full information set on a mobile, but you can have the information that's contextual and available and important for the moment in time. And for a lot of things like laboratory results, that might do well on a smartphone. For bigger, slightly more complex data sets and textual information would do well on a pad. But the full sort of panoply of information, images and multiple windows is going to rely upon some sort of fixed desktop model.
Right. That connects to a question from Marie Carey, who says, what does the support to GPs to manage more acute patients in the community look like?
Well, the first thing is we try not to put limits on it. Certain things we put parameters around. So, for example, a patient with a transient ischemic attack and a low risk transient ischemic attack, the GP can access the ultrasound of the carotids, the CT of the head, has phone access to the acute neurology service to define precisely what treatment they want to use. The patient who has cellulitis can have intravenous antibiotics, a line put in by the community nursing team, drugs administered by the community nursing team, can have a relationship with the infectious diseases team to give 24-hour drug infusions. So it's not so much about hospital outreach, it's about the GP defining where they are, what services they need, and us making sure we can provide them. Other services would be additional home help, home nursing, for children observation, because often for children the GP sees them in the surgery and says, I'm not sure which way this is going to go, knowing that most children bounce back quick, but some don't. And they can go to an observation center run by the GPs in their after-hours surgery and spend 4 or 6 hours there to make sure things are improving. So we try and be as flexible as possible.
Yep. Great question here from Malt again. Does all of this mean that you've largely eliminated paper records?
Sadly not, because paper is like, you can't kill it, We're working really hard. Yeah. I think we should order a whole bunch of paperless printers, would help us.
Yeah.
It's a struggle. What we're doing is going through the medical record and just knocking off things. Now, many of our GPs are paperless. I've got a GP colleague who's been paperless for 20 years. So we know it can be done. In the hospital, we're just going through. We've thrown away all those correspondence, all letters, all the lab results have gone. A lot of the administration documentation's gone. We've just got a project going now to look at in-hospital observations, pulse, blood pressure, etc., and all those early warning scores. When that's running, we'll throw away observation charts. We're just implementing our eMeds program. So then we'll throw away all the medication charts. And as we go through, we're stripping things out. So now there are 3 or 4 services that can run paperless in outpatients. The oncology service said all we've got to crack now is the consent form, and we'll go paperless in outpatients. So We're nearly there for some services and outpatients, but not yet for inpatients.
Right. Okay. Do you? We've got just a few minutes left. Do you support telehealth consultations and capturing occasions of service? A question from Philippa Brown.
I believe that's a workable model. We've all done it by phone. The key thing is you have to have it's best to have a relationship with the clinician first and have a context, and you're working to a plan. That becomes something quite straightforward, like a simple consultation. Those pills you gave me, doctor, are now making me feel sick. What should I do? Does not need the person to, return to have a complete review or a discussion about blood pressure. So we have opportunities to do what's been done in Kaiser Permanente, where you can move some of those face-to-face to remote-based, either asynchronous through messaging or live through some form of phone or voice contact. And then free up time to spend more time with people about the things that really matter.
Let me ask you this final question, which I think is a great one to end on. Andrew Knight says, why were you able to do this in Canterbury when other areas in New Zealand and the world have not? What's the magic ingredient that leads to change in a region?
Yeah, that's a tough one, that really. I mean, I suppose what makes the Crusaders rugby team the best in the world? It's the same process. I think we're fortunate through geography, but we just happen to have struck the right people. But I think it's commitment and vision and taking some bold steps and actually sharing out the responsibility and not trying to control things. And the last line I would say would be use a model of adaptive leadership, which you might have to look up.
There you go. Tom Chapman's arguing that not last year. I think that's a reference to your rugby comment there.
True. I'll give that one away.
Yeah. Well, let's conclude there. Thank you, everybody, for joining us. A couple of quick things to let you know that we will be sending out a link to this video to all attendees. I hope later this afternoon, as we publish that video. We will also be publishing a video on ehealthspace.org later in the week and a short review of today's webinar. So please do check out ehealthspace.org. I'd like to thank David Hepburn from Orion for hosting and for introducing our webinar today. And to you, Nigel, thank you for a fantastic presentation. We've got some great feedback here, and I know that people have really got a lot out of today's presentation. Thank you for being so generous with your time.
It's been a pleasure.
And finally, there is a short survey for everybody who is still here. In fact, many of you are still here, which is great. To let you know that there is a short survey that will come up at the end of the webinar. We'd really love your feedback. We do believe in constantly improving the webinars. We're very keen to get your feedback and to improve it next time. So again, thank you everybody for joining us today. It's been a fantastic conversation. Do come back to ehealthspace.org to review the presentation again, and we look forward to seeing you next time. Thank you.